Immunology Insights, Basics and Beyond, Chapter 56, Treatment Strategies for Allergies and Asthma. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our last two chapters, we explored how allergies arise and how chronic inflammation in the airways leads to asthma. Today, we shift from mechanisms to management. Allergies and asthma affect hundreds of millions worldwide, and while we cannot yet switch off these conditions entirely, we now understand the pathways well enough to intervene at multiple levels: symptoms, inflammation, and even the immune system's underlying miscalibration. So let's talk science. Let's first look at the goals of treatment. What are we trying to achieve? The purpose of therapy in allergies and asthma is not simply to relieve the symptoms. Modern treatment aims for a much broader and more strategic set of goals. First, symptom control. Patients should be able to breathe normally, sleep through the night, exercise, work, and live without major interruptions. Uncontrolled symptoms, wheezing, itching, congestions, are signs that deeper inflammation is ongoing. Second, reducing inflammation and preventing long-term damage. Chronic allergic and asthmatic inflammation leads to airway remodeling, thickening bronchial walls, increased mucous glands, and hyperactive smooth muscle. Preventing this is a major target for therapy. Even when symptoms seem mild, silent inflammation can continue beneath the surface. Third, preventing exacerbations or attacks. Severe asthma attacks remain a global cause of hospitalization and even death. Good treatment lowers the risk of life-threatening bronchoconstriction triggered by allergens, viral infections, exercise, or pollutants. And fourth, restoring immune balance rather than simply blocking the symptoms. Many therapies, particularly immunotherapies and biologicals, aim to correct the underlying immune imbalance, shifting from a Th2-dominated IgE-driven response towards a more stable regulatory pathways. Now, let's look at some treatment approaches in more detail. First, we have pharmacological treatments and how the respective medications work. We have antihistamines. These drugs block the H1 histamine receptor, a receptor on smooth muscle cells, endothelial cells, and nerve endings. Histamine activates H1 to cause itching, sneezing, vasodilatation, swelling, and mucus secretion. By blocking H1, antihistamines reduce symptoms quickly, but they do not reduce underlying inflammation. We have the inhaled corticosteroids, or ICS, the cornerstone of persistent asthma therapy. Corticosteroids suppress multiple inflammatory pathways, including cytokine production, so IL-4, IL-5, and IL-13, eosinophil recruitment, and mucus production. Used regularly, ICS prevents attacks and airway remodeling. We have long-acting beta-2 agonists, or LABAs. These bronchodilatators relax airways' smooth muscle through B2 receptor activation. They improve airflow but must always be paired with ICS in asthma, since bronchodilation without anti-inflammatory control can mask danger. We have leukotriene receptor antagonists, or LTRAs. These block the cysteinyl leukotriene receptor on airway smooth muscle, preventing leukotriene-induced bronchoconstriction and inflammation. Used in aspirin-exacerbated respiratory disease and allergic asthma. And we have short-acting beta-2 agonists, or SABAs, the classical rescue inhalers for acute symptoms. They are not a substitute for long-term treatment, but can give short-term relief. Second, we have the immunomodulatory and biological therapies as precision approaches. Modern biologics target specific molecules in the allergic cascade. We have anti-IgE, for example, omalizumab, which binds circulating IgE, preventing it from attaching to the Fc epsilon R1 receptors on mast cells and basophils. This reduces mast cell sensitivity and decreases the intensity of reactions upon allergen exposure. B, we have anti-IL-5, for example mepolizumab or reslizumab, and anti-IL-5 receptor, for example benralizumab. IL-5 is the key survival signal for eosinophils. Blocking IL-5 or its receptor reduces eosinophil numbers dramatically, especially valuable in eosinophilic asthma. And C, we have anti-IL-4 and anti-IL-13, for example dupilumab, which blocks the shared IL-4 receptor alpha used by IL-4 and IL-13, two central Th2 cytokines. This suppresses IgE class switching, mucus production, and airway hyperreactivity. These therapies are expensive but transformative for patients with severe refractory disease. And third, we have allergen immunotherapy or desensitization. Allergen immunotherapy or AIT, whether by subcutaneous injection or sublingual drops or tablets, is the closest we have to a long-term reset of the allergic immune system. Let's look at the mechanism in brief. Gradual exposure to controlled doses of allergen changes the immune response from a Th2 dominant IgE production to induction of Treg cells and IgG4 antibodies. IgG4 here acts as a blocking antibody, preventing allergens from reaching IgE on mast cells. Over time, mast cells and basophils become then less reactive. The results include A. Fewer symptoms, B. Reduced medication needs, and C. Long-term improvement even after the treatment ends. AIT is especially effective for pollen, dust mite, venom allergy, and selected food allergies. Now that we looked at the three main medication classes, let's also look at environmental and lifestyle management, so everyday measures that matter reducing the exposure. Allergen avoidance is never perfect, but reduction in dust mites, pet dander, and mold can significantly decrease baseline inflammation. Lower inflammation also improves the effectiveness of medications. First, we have air quality and pollutants. Smog, particulate matter, diesel exhaust, and even indoor pollutants increase airway sensitivity and promote Th2 inflammation. The conclusion is straightforward. Better air means better control. Avoiding smoke exposure, using clean indoor air sources, and ventilating living spaces all reduces exacerbations. And second, we have of course tobacco smoke. Active or passive smoking directly increases airway hyperreactivity and accelerates lung damage. In short, for asthma or allergy patients, smoke-free environments are essential and not optional. Now, what are the future directions, or how can we teach the immune system tolerance? While symptom control has improved dramatically, the ultimate goal is immune reprogramming, restoring tolerance to allergens without long-term medication. This is where some of the most exciting developments in modern immunology are happening. Researchers are exploring several promising strategies. First, nanoparticle-based allergen delivery. Nanoparticles can deliver allergens directly to dendritic cells in a controlled, safe context. This promotes tolerogenic pathways rather than inflammatory ones, reducing IgE production and shifting the response towards regulatory T cells. Early trials in peanut and dust mite allergies look encouraging. Second, mRNA-based allergy vaccines. Similar to mRNA technology used for COVID-19 vaccines, these constructs encode allergen components designed to promote tolerance instead of sensitization. They may allow precise dosing, fast manufacturing, and lower risk of triggering severe reactions during treatment. Third, we have peptide immunotherapy. Instead of using whole allergens, short peptides representing only the key T cell epitopes are administered. Because they cannot cross-link IgE or mast cells, they avoid immediate allergic reactions while still retraining the immune system. This approach is being tested for cat, grass, and peanut allergy. Fourth, we have the tolerogenic dendritic cell therapy. By generating dendritic cells in vitro that promote regulatory T cells rather than Th2 cells, scientists hope to create a personalized, cell-based treatment for severe allergies. These tolerogenic DCs are already explored in autoimmunity and transplantation and may become part for future allergy care. And fifth, we have the microbiome-directed therapies. Children with diverse gut microbiomes, especially those enriched in Bifidobacterium and Fecalibacterium, are less likely to develop allergies. New therapies aim to restore these beneficial microbial communities to deliver their metabolites, such as short-chain fatty acids, to strengthen immune regulation early in life. Together, these strategies represent a shift from managing symptoms to re-educating the immune system, potentially offering long-term remission or prevention for future generations. To conclude, allergy and asthma treatments span a spectrum, from rapid symptom relief to deep immune reprogramming. Modern therapy doesn't just quiet the immune system, it seeks to reshape it, improving long-term control and preventing future disease progression. As our understanding of immunology advances, we move ever closer to precision treatments that address the root causes rather than the consequences. In our next chapter, we will explore one of the pioneers behind this field, Charles Richet, the scientist who first described anaphylaxis and helped lay the foundation for our understanding of allergic shock. Before closing, I have a small request. If you enjoyed my content and want to hear more, please like and subscribe. It's a small step for you, but it helps me a lot. So thank you for listening and see you next time.